Welcome to the Deep Dive, where we strip away the noise and deliver the crucial intelligence you need for your daily practice.
And if you're an emergency medicine doctor or practitioner in the NHS who sees children and young people, well, this deep dive is absolutely for you.
Today, we're dissecting what is really the definitive new blueprint for pediatric emergency care.
That's right, the fifth edition of the Facing the Future standards.
It feels like a landmark document.
It is, absolutely. It was published in October 2025 after a massive intercollegiate effort. You've got the Royal College of Emergency Medicine, Pediatrics, and Child Health, nursing. Everyone was involved.
And you have to understand the context here, don't you? This isn't just a routine update.
No, not at all. You see, this is a critical system-level response to what has become a defining crisis.
The gap between capacity and demand.
Exactly. A gap that's just been, severely exacerbated by post-COVID recovery challenges and all the acute seasonal pressures we see every year.
And the numbers and the sources really paint a stark picture of that pressure.
They do. I mean, children and young people actually have the highest rate of what the system calls unnecessary ED attendance.
That's surprising.
It is. The document makes it really clear that nearly 40% of all pediatric ED attendances are classified as non-urgent.
40%.
Yeah. That sheer volume, it just creates an immense bottleneck. And that puts the truly sick child at risk because the whole system's just fatigued and overcrowded.
So our mission today is to cut through all of that. We're going to focus on the immediate, actionable standards that you on the front line need to know right now.
Things that target system resilience, strategies for our most complex patients, and critically, new ways to combat that enemy we all know.
Crowding.
Crowding.
Okay, let's unpack this. Let's start with that fundamental problem, managing flow.
Crowding is, I think, the ultimate challenge because it impacts absolutely everything. It's an internationally recognized issue where demand just consistently exceeds your capacity to provide safe care.
And the effects are tangible, aren't they? It's not just about being busy.
No. The consequences are measurable and, frankly, deeply concerning. You see increased morbidity, delays in time-sensitive treatments.
We're talking basic things, like painkillers.
Simple analgesia, antibiotics, yes, and a rise in clinical errors and just catastrophic levels of staff burnout. If you fail at flow, you fail at resilience. Simple as that.
So the document requires this whole system approach, a three-tiered strategy.
That's right. Input, throughput, and output.
Let's focus on throughput, managing patients already in the ED. What's the biggest, most challenging standard they've introduced there?
I think it has to be the one on staffing levels. It's incredibly challenging, but it's essential for safety.
Okay, what does it say?
It demands that ED staffing must be sufficient to cope with at least 80% of predicted maximum demand.
Right, so that's the crucial bit, not average demand.
Not the average Monday afternoon, no. You have to staff for the peak winter surge or the worst shift of the week. This means you need systems for flexing staff up and using models like rapid assessment and treatment, or RAT.
Staffing for predicted peaks. I mean, that sounds like a huge financial and organizational hurdle for every trust. How realistic is that, really?
Look, it requires a strategic, trust-wide approach and, frankly, a cultural shift in how budgets are allocated. The standard knows it's difficult, but it makes it non-negotiable for safe care.
So the system just has to find a way.
It has to develop that flexibility, yes.
Yeah.
Even if it means drawing on other resources or using smarter triage to divert cases before they clog up the works.
Okay, so that's throughput. What about output? Getting patients admitted safely. How does the standard tackle the problem of, parking admitted patients in the ED?
It's designed to stop that practice cold. The goal is that an admission to an inpatient ward should happen within 1 hour of the patient being deemed clinically ready to proceed.
1 hour.
1 hour. This isn't just about bed management. It's an acknowledgement that once that decision to admit is made, leaving a child in a noisy, high-risk environment significantly increases their risk of harm.
And achieving that requires the whole hospital to be on board.
Real-time bed visibility, senior management buy-in, the works.
So flow isn't just about what happens inside the ED walls, it's about protecting those walls. Let's talk about solutions designed to preserve that acute capacity.
Yes. The whole idea is that you have to develop capacity out in the community.
We saw that with the ARI hubs during the big surges, but the documents highlight a really remarkable example, the PAETCH model.
A PAETCH model is fantastic. It stands for Providing Assessment and Treatment for Children at Home. It's running in Northwest London, and it just shows what's possible.
So what is it?
It's a nurse-led, 7-day-a-week service. They use augmented phone and video reviews, plus home visits to manage acutely unwell children in their own homes.
And the results? How successful has it been in real numbers?
The numbers are, well, they're staggering. They should be a wake-up call for every system manager. In 2023-24 alone, PTCH saved over 3,000 bed days.
3,317 to be precise. Incredible.
Incredible. And at one trust, it managed to have bronchiolitis admissions in its first year. And the cost savings, over £500,000.
So this isn't theory. This is proven capacity creation that directly takes pressure off the ED.
Exactly.
Okay, let's move from that system-level flow to the actual patient encounter. Let's dive into the core frontline standards for rapid assessment. First up, triage.
Correct. The first clock starts ticking the second they arrive. A formal triage assessment has to be done within 15 minutes.
And if that's not possible because of crowding, which, let's be honest, happens.
It does. And if that standard is breached, a rapid system of prioritization must be immediately put in place. You can't have a time-critical patient just sitting in a queue, unseen.
And once that patient is being triaged, what data is absolutely non-negotiable?
The standard is much clearer now. For all children and young people, you need a full set of vital signs, a measured weight, and a pain score.
And crucially,
The vitals must include blood pressure, BP, alongside a GCS or AVPU score. It doesn't matter how well they look. These are fundamental.
that comprehensive set of vitals is essential, and it leads directly to the standards around pediatric early warning systems, or PUWS.
Absolutely. The use of PUWS is central. And the document confirms the impending system-wide rollout of the new ED National PUWS in England, which is great because it will align with the inpatient chart.
Which is critical for handover.
Critical. And the standard is clear. Any abnormal vital signs you pick up at triage have to be repeated within 60 minutes. Or sooner, obviously, depending on how sick they are. That 1-hour window is a major safety indicator.
Sticking with time-critical targets, pain management has always been a bit of an Achilles heel, hasn't it?
It has. But these standards treat pain with the same urgency as any other life-saving intervention. And that's a huge step forward.
So what's the target?
Analgesia for moderate and severe pain must be dispensed within 20 minutes of arrival in the ED.
Wow. 20 minutes.
20 minutes. And this demands system reorganization, not just clinical willpower. Plus, you have to go back and reassess their pain score within 60 minutes of giving the medication.
20 minutes is incredibly tight, especially with prescribing, dispensing, everything else going on. What's the immediate challenge you see in hitting that target?
It's twofold, really. First, resources. Nurses need the time and access to meds. Second, it's about prioritization. Clinicians have to view pain as that fifth vital sign and act on it immediately. The standard is forcing us to treat pain as a critical patient safety benchmark.
Okay, shifting to the sharp end of care, resuscitation readiness and advanced airway management. Any specific new technical requirements there?
Yes. Beyond the obvious need for age-appropriate kit, the document mandates a key safety measure: the use of waveform capnography whenever you use an artificial airway.
For definitive confirmation.
Immediate definitive confirmation of tube placement. And it goes without saying, all staff who might manage a pediatric airway need regular, hands-on training.
And finally, for this section, transfers. For those kids who need to go to a specialist center.
Well, the system relies on the Regional Pediatric Critical Care Transport Service, the PCCTS, which has the 24-hour advice line. But, and this is important, local hospitals must have the skills and kit to do time-critical transfers themselves.
So when waiting for the retrieval team is just too risky?
Exactly. When the clinical risk of delay outweighs the risk of a local transfer, it's a huge call, and it has to be a consultant-to-consultant discussion.
Right. That covers the clinical engine room. Let's move into the realm of complexity, which seems to be a growing part of the job, safeguarding and mental health.
Yeah, and here we're moving from purely clinical standards to infrastructural ones. For safeguarding, every ED must have a lead consultant and a lead nurse.
With shared responsibility.
With shared responsibility for child protection. It diffuses the burden and ensures there's always cover.
And getting information quickly is paramount in these cases.
Crucially, yes. The requirement is for 247 access to child protection plan or register information. In England, that's via the CPIS system.
So you can see immediately if a child is known to services.
Instantly. And it informs everything. The document also lists specific high-risk presentations that must be reviewed by a senior decision-maker before discharge.
Like what?
Like a non-mobile infant with a suspicious injury, or a perplexing presentation that doesn't quite add up, or any unaccompanied adolescent. That senior review is a vital safety net.
The standards also tackle frequent attenders, which can be a really challenging group.
They do. They suggest a pretty sophisticated two-tier approach. There's a short-term trigger, which is purely clinical, to make sure you don't miss an emerging illness just because you know the patient.
And the long-term one.
The long-term trigger, tracked over a calendar year, is there to identify patterns. Often these patterns point to underlying safeguarding issues or unmet social needs that need a full multi-agency review.
Okay, now onto the mental health crisis. The statistics are just horrifying. 20% of children aged 8 to 16 with a probable mental health disorder.
And that influx has created a crisis within the crisis in the ED. We're seeing reports of children waiting over 12 hours. And in some areas, the wait for a specialist EMHS assessment can be up to 5 days.
5 days? In an emergency department?
In an emergency department, it's an environment that's completely unsuitable for a young person in that state.
So, given the constraints, it's noisy, it's brightly lit, what specific standards are there to try and mitigate that distress?
The standards require explicit, reasonable adjustments. Things like using quiet spaces with audio-visual separation, having low lighting options, and making tools like ear defenders readily available. It's about trying to manage that sensory overload.
And to get ahead of the crisis, the documents also endorse using specific screening tools.
Yes, tools like the ESPF's web-based app. It's a comprehensive framework. Home, education, eating, activities, drugs, and so on.
And the key insight here is how young people use it.
It's crucial. A study found that 74% of adolescents actually prefer to fill it out independently. This gives them a safe space to disclose really sensitive information about violence or exploitation without the pressure of a face-to-face conversation.
That idea of a reachable moment leads perfectly into the King's College Hospital youth worker example. This feels like the ED stepping into a real public health role.
It's an outstanding model. You have youth workers embedded right in the multidisciplinary team. They engage young victims of violence and exploitation, and the numbers are high. 60% of their referrals are assaults, 25% sexual violence.
And what do they do?
They intervene right there in the chaos of the ED visit. They build trust, create immediate safety plans, and ensure a safe handover to community support services. They're actively trying to break the cycle of violence.
That blend of clinical and social support is central to the whole document, isn't it? Let's finish by looking at the complex patient and the workforce needed to make all this happen.
For children with complex needs learning disabilities, neurodivergence, the core standard is a needs-based, not a diagnosis-based approach. And clinicians must be so vigilant against a key barrier.
Which is?
Diagnostic overshadowing.
Okay, explain what that is, because for practitioners, this is a very real risk in a busy department.
Diagnostic overshadowing is when a new acute illness gets wrongly blamed on the child's underlying condition. For instance, you attribute a new abdominal pain to their cerebral palsy, and you miss an appendicitis. The standards are clear. You must look beyond the existing diagnosis every single time.
And what documentation should staff be looking for immediately to help prevent that?
2 critical documents. First, the Emergency Care Plan, or ECP. That has details on emergency management. Second, the Health Passport, which has all the non-medical information communication needs, sensory issues, things like that. Using them is core to providing equitable care.
Right. Turning to the workforce itself, the document affirms the dual training pathways for pediatric emergency medicine consultants.
Yes, from both the emergency medicine and the pediatrics colleges. You get that complementary blend of skills from trauma to complex safeguarding. But
Yeah.
the document highlights a major system inequality. There's huge geographical variation in where these consultants are. They cite the Northeast having good ratios, for example, while the East of England has very low ratios.
And how does that inequality affect the practitioner listening to this right now?
It dictates their access to immediate senior advice. If you're in a poorly staffed region, that time-critical advice for a crashing child or a complex safeguarding case might just not be there. It's a huge issue for patient equity.
And what about the minimum nursing standard?
It's unambiguous.
Right.
A minimum of 2 registered children's nurses on shift at all times. And at least one of them has to hold an APLS or equivalent qualification.
And let's not forget the crucial MDT support roles.
No. The document really emphasizes the role of play specialists. It frames them as a universal right for children in the ED. Their role in distraction during procedures is just vital. And it also recommends a dedicated lead professional for children with complex needs.
Finally, continuous improvement. They talk about integrating research through networks like PAIR-UK.
Yes, PAIR-UK is the Pediatric Emergency Research Network in the UK and Ireland. It's vital. And their latest research priorities mirror everything we've talked about: sepsis, mental health, overcrowding, trauma, communication. The standard says all EDs have to review this kind of published research to inform their local improvements.
Okay, so let's try and pull this all together.
So to summarize the really high-impact changes for ED practitioners, you have to review your department's compliance with that 15-minute triage window. You need to formalize how you're going to meet and audit the 20-minute pain management target. You have to implement the senior review criteria for high-risk presentations. And you must integrate checking ECPs and health passports into your routine assessment. It covers everything.
And while all these new metrics are critical, we keep coming back to this underlying thread weaving through the whole document: health inequalities.
We do.
We mentioned the youth worker model, and that focus on social determinants is clearly not an accident. The source material drives home a really powerful, unavoidable fact.
Which is that children from the most deprived backgrounds are 58% more likely to attend the ED than those from the least deprived.
58%.
That one statistic confirms it. The ED isn't just a place for acute illness. It's a primary indicator of systemic social failure. That attendance pattern puts the ED in a unique position. A safety net, yes, but also a window into these profound socioeconomic problems.
Which leads us to our provocative final thought for you to consider this week. The ultimate standard of emergency care, as outlined in this 5th edition, requires you, the clinical staff, to leverage the unique position of the ED to act as agents of public health improvement.
It's a huge ask.
Yeah, it is. So the question for every ED practitioner isn't simply, did I manage the child's fever correctly? But how do I intentionally use that mandatory 15-minute triage window, that brief moment of stability, to address the deep-rooted factors that keep bringing my most vulnerable patients back? Are you geared up structurally and culturally to go beyond the clinical and signpost families to resources like the Citizens Advice Bureau, shelter, or local family navigators, to make that brief encounter a true touch point for systemic, lasting change? That really is the challenge of the new blueprint.